Good afternoon. Thank you very much for the opportunity to speak to you today. My name's Tom Poulton, and I'm going to be talking through some work that I've done on the interactions between socioeconomic status and outcomes and standards of care for patients undergoing an emergency laparotomy in England. This is using data taken from the NELA dataset, and the analysis I've done is for those patients who underwent surgery between the 1st of December 2013 to the 30th of November 2016. It was limited only to those patients undergoing surgery in English hospitals. So that was 178 hospitals, totaling 58,790 patients. So the first thing to talk about is how we've gone about defining socioeconomic status for the patients contained within the NELA dataset. This was based upon the postcode of the patient's usual area of residence, where that was recorded, or if it was missing, the data contained within the HES, Hospital Episode Statistics database, to which we were able to link for the spell containing the emergency laparotomy that was included within the broader dataset. So for this analysis, we've used the Index of Multiple Deprivation, or IMD, and in England, this is comprised of 7 domains of deprivation based around income, employment, education, health, crime, barriers to housing and services, and the living environment. Each of the 4 constituent countries of the UK has a similar version of IMD. However, they are based around different statistics, different metrics, and the different metrics are also given different weightings. Therefore, they are not directly comparable. NELA only collects data from patients undergoing surgery within England and Wales. And unfortunately, patient-level data needed for some of the subsequent analyses were not available for patients undergoing surgery in Wales. Therefore, for these reasons, this analysis was limited only to those patients undergoing surgery within English NHS hospitals. IMD is not expressed at patient level. Instead, it reflects the population within a geographical footprint. The smallest footprints for which data are available are referred to as lower layer super output areas, of which there are 32,844 within England. These vary in geographical size, but have similar populations, roughly around 1,500 residents per LSOA. The IMD deprivation score is calculated for each of these LSOAs based on the statistics relevant to the populations that they contain, and each is then ranked from most deprived to least deprived. This ranked list is then broken down usually into deciles or quintiles for comparison. It's not appropriate to directly compare the deprivation score of one LSOA with another. The most appropriate form of analysis is to compare between these ranked groups, deciles or quintiles. For the purposes of this analysis, to ensure adequate cell sizes and reasonable populations within different groups, I've restricted my analysis to quintiles. In terms of why socioeconomic status is important, we know that there are wide socioeconomic inequalities, both in health and various other measures across England. Taking 2 particular measures, the slope index of inequality and the relative index of inequality for life expectancy at 75 years, we can see that there both exists socioeconomic disparity and also that the extent of that disparity is growing over time. For both of these measures, a positive value suggests that patients at the more deprived end of the spectrum do worse than those at the less deprived end, and the higher the value, the greater that disparity. So the fact that both of the values are positive means that there exists a disparity, and the fact that both values are growing over time suggests that the difference between more deprived and less deprived is also growing over time. This effect can also be seen when looking at the change in life expectancy at birth between 2012 to 2014 and 2015 to 2017 by IMD decile and sex. And what you can see is that patients at the least deprived end, so IMD decile 10, are gaining in life expectancy, whereas those at the most deprived end, IMD decile 1, are losing in life expectancy. And this is most pronounced for females compared to males. We can also see that total life expectancy and healthy life expectancy vary according to IMD decile. People who are less deprived tend to have both longer life expectancy in terms of absolute time and also longer healthy life expectancy. In addition, they spend a greater proportion of their longer life in good health, whereas people at the more deprived end of the spectrum both have shorter life expectancy in terms of absolute time, fewer years spent in good health, and a greater proportion of their shorter life expectancy lived with good health. These differences in self-reported good health begin at a relatively early age. Taking the solid line as the most deprived IMD quintile and the dotted line as the least deprived IMD quintile, you can see that for the most deprived patients, the self-reported health really starts to dip and the lines start to diverge from the late 20s to early 30s onwards. Whereas for those in the least deprived quintile, the decline in self-reported good health really only starts from the late 50s onwards. Since the NHS in England is a single universal access healthcare system, free at the point of use, it's reasonable to expect that any given patient should expect equitable levels of care regardless of which hospital they present to. Since we've defined deprivation based upon geographical footprints, and since in the case of emergency surgery, patients are most likely to present to the nearest appropriate hospital, it's reasonable to assume that hospitals surrounded by communities with high levels of deprivation are going to treat a higher proportion of deprived patients within their overall case mix. And this has implications for the resourcing for that hospital and the acuity and the relative comorbidity of the patients that they treat. If we look at this graph, which represents all 178 hospitals within this analysis, you can see that there are some hospitals at the left-hand side of the graph that treat very few very deprived patients. So the proportion of this is the proportion in the most deprived IMD quintile, the most deprived 20% nationally. However, at the right-hand edge of the graph, there are some hospitals where 2 in 3 of their patients are from the most deprived 20% nationally. So again, this would have significant resource implications for how those hospitals are run, and would also then have health policy and health funding implications in terms of how resources are made available for each hospital to be able to provide care to its local community. If we look at this spatially, we can see that there is geographical bias in terms of where hospitals that treat a high proportion of deprived patients tend to be located. Deprivation in England is predominantly a feature of urban conurbations and is also more prevalent in the north of England. Therefore, hospitals situated in major cities, and especially major cities of the north of England, tend on average to treat a higher proportion of the most deprived patients. The actual relationship between socioeconomic status and postoperative outcomes is incredibly complicated. This diagram is not intended to be exhaustive, merely to demonstrate the fact that there are a number of interactions, mediators, and confounders that may lie upon any hypothetical causal pathway. Since patients presenting for an emergency laparotomy are, by definition, emergencies and with limited opportunities for any pre-optimization, patients need to be treated as they are. The only factors that the hospital and its staff can influence during the immediate perioperative period are therefore the quality of care that they provide, and therefore that has been the focus of the analysis that we've performed, looking at the adherence to various standards and metrics measured within NELA. On an international level, looking at the wider literature, the associations with socioeconomic disadvantage of deprivation are numerous. Patients who are more deprived are less likely to be treated in teaching hospitals, less likely to be operated on using a laparoscopic approach, less likely to receive sphincter preserving surgery, less likely to receive negative resection margins, or adequate lymph node examination and clearance. They're also less likely to have adjuvant chemo or radiotherapy. They're also more likely to present with advanced stage of disease, with greater comorbidity, greater levels of urgency, or undergo high proportions of palliative surgery. They're also more likely to undergo non-surgical management, be treated in a low-volume hospital or by a low-volume surgeon, more likely to have an anastomotic leak or abscess formation, more likely to need a colostomy, more likely to need a reoperation, and have a greater length of hospital stay. Thankfully, from the perspective of the English NHS, patients in the most deprived quintile were as likely, if not more likely, to receive good perioperative care according to the metrics laid out in NELA, and be treated in hospitals with good organisational structures and processes. However, even after risk adjustment, patients from the most deprived quintile had worse 30-day mortality than all other quintiles. While good perioperative care is undoubtedly important, there was no evidence that the quality of care explained the difference between socioeconomic groups. Just treating sick people better during an acute illness didn't fix the existing disparities. The overall conclusions of this work were that the English NHS provide equitable acute surgical care for people needing an emergency laparotomy. However, the causes of socioeconomic disparities are numerous and are related to broader economic and political structures within society. Addressing health disparities therefore needs to begin well before a presentation with an acute illness. Thank you very much for your time. I'd be happy to take any questions during the panel discussion.